So thank you very much, everybody, for coming. So today we have the pleasure of having Dr. Amol Verma, who's coming from Toronto, and he's going to talk to us about harnessing hospital electronic health records data for research and innovation. And he is our guest within the division of GIM. And so he's got a lot more work than he thought. So he's also presenting with a small group at 4 and then at 6 again. And so, of course, he wanted to come to Montreal to visit, but he's going to be stuck with us the whole day. Essentially, I'm just going to give you a bit of information about Dr. Verma. So after completing medical school at University of Toronto, and he obtained a master's degree in economics and social history at the University of Oxford, as a Rhodes Scholar. And he did 1 year interdisciplinary fellowship with the Canadian Frailty, 2-year fellowship studying big data and advanced analytics through the Elliott Phillipson Clinician Scientist Training Program. And so currently, Dr. Verma is a general internist and scientist at St. Michael's Hospital at University of Toronto. And he's, I don't know how to pronounce it, Temerty Professor of AI Research and Education in Medicine at U of Toronto as well. Did and co-lead, I believe, will be part of this discussion, which is Canada's largest hospital clinical data research network. Includes 30 hospitals in Ontario. And so we have here, as you know, the data warehouse with David Buckridge, who is leading this, and Dr. Verma and Buckridge actually are collaborating on projects, which I think we'll hear about. And so I think I'll stop here, Amal, and I'll let you take over. Thank you for coming.
Thank you so much for having me. It's really a pleasure to be here. It's so funny to be holding a microphone that doesn't work in the room but works on Zoom. I feel like I have a 7-year-old daughter and she does this all day with like a fake microphone singing around. Anyway, that's what I feel like. The other thing I will just say before I start is that I've come to learn over the years that good leaders get you to come and do a little thing and then do way more work than you expected. And I have come to learn that Suzanne is an amazing leader because I'm doing like 3 different things from the one thing. So she's definitely compelling. So it's really a pleasure to be here and share some of our work with you. Just up front, I should also say, when they asked me to do this extra kind of presentation, the Not for the Clinicians, I got kind of excited because this is like the nerdier of the talks. I hope that's okay, in that it'll be a little more methodsy, not like statistical methods so much, but getting a bit into the weeds related to data quality, those kinds of things, which like clinical audiences don't usually care about. I hope I'm reading the room correctly, that this room cares about things like data quality and research methods. So I'm pleased to be able to give a talk like this. Upfront, just disclosures. I don't think I'm actually in this presentation going to speak at all about the work that I did. I co-invented an AI early warning system for patient deterioration in hospitals, which my hospital then sold to a startup company called Signal One, giving me an indirect relationship with the company. But I don't think we're going to talk about it. Okay, so today, I'm just going to introduce you to the work we've done with a hospital data platform called GEMINI, which has no relationship to Google's Gemini AI tool thing. I'll speak a little bit about our methods of data collection and quality, speak about some applications in health services research, and some applications related to AI. So underpinning all of this, I finished my medical residency in 2016, and started this work for us really started in around the last 2 years of my residency as a 4th and 5th year resident. And what was happening around us at the time was the digitization of our hospital data systems, which obviously has continued, right? So that now we have the ability to, if you take a clinical interaction or encounter like this, every single one of these little bits of information has some representation somewhere in the electronic health record. And that information can be gleaned and put together for an extraordinary amount of research, but is historically just not been available. What has been available in Canada has been obviously this rich backbone of administrative data, right? All of the transactions that happen in our healthcare system and a certain amount of pretty high level clinical detail, things like someone's diagnoses and how long they stayed in hospital. Uh, it's shared largely through the Canadian Institute for Health Information, though I put an asterisk there because I think maybe not from Quebec, but you share kind of similar data in other ways. What's not represented is all of the clinical data that exists in the electronic health record, right? Whether it's, operational data about hospital operations, not like operating rooms, but like how does the hospital work? So every room transfer that a patient has, the details about who's seeing that patient every day, blood tests, medications, all the imaging. In Ontario, we have actually quite rich data about medications in the outpatient setting, and I know that Quebec has very good data about that as well. But the inpatient medication data is a total black box. Like no one has as to what medications are prescribed for patients in hospital. So all of that is what has not historically been shared well and challenging to access for research and innovation in Canada. And so that was really the focus of our work, was saying, can we get all of this data and make it useful? Of course, it's not just about taking that data and standardizing it and linking it and making it usable for research. That's for sure the first step. That data also needs to sit in an environment that has computing resources. And today with AI, they need to be fairly powerful. It also needs to have the right sort of research software stack around it, right? And then it needs to be surrounded by the appropriate, this might be the hardest part, ethics, protocol, privacy, compliance, and the governance, not just to make the data like beautiful and locked up somewhere, but actually very accessible and usable for research. The other day, I was in a call with someone who's building a supercomputer at a university. And we were asking him about how well they were making data available and his experience with using health data. And he said, I have a ton of experience with nuclear secrets data. And so health data is just the same as that. And I said, actually, it's not at all the same as that. Because while both are sensitive data, nuclear secrets you want to keep locked up and you don't want people to use. What we want is to make these data as usable as possible for as many people as possible. It's a very different task, right, of governance. But how do we do that while also protecting the privacy of that data? So that's what we've been trying to build. And we've been building it with something that we've called the GEMINI data platform. It was originally called the General Medicine Inpatient Initiative, GEMINI. We've since dropped it because we are not just focused on general medicine. We currently collect electronic health records data and administrative data from about 37 hospitals, getting close to 40 in Ontario. That represents more than 60% of the province's patients. We receive data not for every patient in the hospital. This is also because the project has kind of grown organically over time, but for every medical admission, every ICU admission, and every pediatric admission, we receive data. So what's missing is surgical and mental health. And the data are all collected under research ethics protocols. So we have a parent REB protocol that allows us to collect all the data, and that has broad objectives. And then when someone wants to do a project with the data, they actually don't need their own REB approval. They submit a brief project proposal that's an amendment to our parent REB, and that allows us to, and then our hospital's REB that governs this, because there's a REB structure in Ontario called Clinical Trials Ontario, which kind of harmonizes REBs for all the hospitals in the province. They agree to defer decisions to a single board of record. And so our hospital serves as that. And so what that means is we get 4-week REB turnaround on every project proposal that comes through when people want to do projects, which is really extraordinary. We take all the data, it comes into our hospital, we put it into a computing environment within our hospital. I'll tell you a little bit more about that. And so we currently hold data for roughly 2.5 million hospital visits. It's about 20 billion data points. And perhaps most importantly, the data are available to a broad community. So more than 1,000 clinicians log in. They get individual performance data, which I'll tell you a little bit about, researchers and students. So we have about 110 active projects, and researchers, individual investigators write grants so that they can then use these data. And so the platform has contributed to grants totaling more than $140 million. But most of those grants, much to the chagrin of my VP of Research and Innovation, are not held at my institution. They're held outside of our institution because it's a system resource, which is what we're really excited about. That's why we wanted to do all the work of collecting this data. So how do we collect the data? We hospital a data reference model, which means it's a very high level description of what data we want each hospital to extract for us. So that defines sort of 25 tables, it defines the patient cohorts, and the tables are split up into sort of administrative data and clinical data. And then we have sort of three patient cohorts that are defined. We share that with the hospital's IT and decision support, whoever runs their sort of data operation. It's different at each hospital, and sometimes it's multiple people. Each hospital actually figures out themselves how to do the extraction, but we keep it very light touch. So we don't say, give me labs with this specific naming of each lab test, for example. We say, just give me all your labs, give me all your imaging. And so what we get is a mess. We get very messy data about, with different naming of each data element at each site, different. And then all of that work of data quality checking and standardization is what we do internally. And this allowed hospitals to participate with a low barrier to entry, and also allowed us to be kind of the stewards of the data quality. So I'm not going to spend a huge amount of time walking through the whole data flow here on the slide. But if you start at the top left-hand corner, which is the participating hospitals, what happens is they extract the data, they dump it into our hospital, and we split the data environment into multiple zones. So the first zone is where we hold personal health information. So we actually get things like health insurance numbers. That allows us to then encrypt that identifier, and we can track patients as they go to different hospitals over time within the network, for example. So we can follow them longitudinally. The first thing we do actually when we receive the data is some quality checking just to make sure the data kind of roughly looks like we think it should. And then we de-identify the data. Then the data get moved into a processing zone where we do a lot more quality checking. I'll give you a brief explanation of some of that. And then actually it gets spun back to 5 here, where actually we then push the data back to the hospital after we've kind of cleaned it up, and we say, now you have to manually validate a subset of the data. So actually someone at the hospital pulls up the hospital's electronic medical record. They manually collect some selected data elements for a number of records, and then we compare that with what we hold to make sure that the data are high quality. Having done all of that, we then kind of standardize the data. We have a standardization to this OMOP common data model. Some of you may have worked with that. It's a sort of a standard that people are using now to sort of standardize a common vocabulary or a common data model for medical data. We also have our own internal data standard, and then we have this live database which we use to push out to our final zone, which is the research and reporting zone, so that when researchers come and say, hey, I need a data cut for this project, we actually don't disclose the whole database to them. We're not allowed to do that by privacy rules in Ontario. We have to limit the disclosure to exactly what they need. So what happens is people submit a project proposal and they define like what cohort they want. And then our team is able to pretty efficiently cut a database for them. And then they get a database in their zone, and then people can remotely log in and use their database. We also use that to generate quality reports. So that's kind of the data flow as we work through it. So maybe I'll just spend a second talking a little bit about de-identification. So we spend time checks. Yeah, I'm going to keep my phone there so that I can keep it. No, I'm not checking my text messages. I'm not that bad. Okay. So, obviously de-identification of the data is really important if we're going to share it to researchers. A portion of the de-identification is really straightforward because we have a variable that, for example, says, a health insurance number, right? Or date of birth. That's really easy. You just strip it out and we store it separately. But what's more challenging is we receive narrative clinical notes. So you receive like the full doctor's note, right? Embedded in the doctor's note may be all sorts of identifying information. It could be the patient's name. It could be their sibling's name. It could be where they used to live. There's just so much information that's collected there. So trying to de-identify that is a challenge. It's also a challenge that many people have worked on, and there's many companies actually devoted to doing this, increasingly using large language models, which do this very well. There was this open source software developed out of, I think it's like the MIT Harvard group called, they run a program called PhysioNet, which underpins the like Mimic database that maybe many people might have heard of. So they had an open source software. We took that and we updated it, and we made it specific to the Ontario context. So we added in Ontario place names and dictionaries of Ontario names and things like that, health insurance number standards, all that stuff. And then we kind of turned it into a Python script so that it's really efficient to run. And then we validated it. We validated it on our data, on some American data, and on some synthetic data. And it works quite well. It's able to identify personal health information with roughly 95 to 99% accuracy. And so we run this over all of the clinical notes that we receive to sort of try to de-risk them. So the way it works is it grabs, let's say, Dr. Amol Verma Satrang Shen. It identifies names. It tags the kind of personal health information. So I think it has like 14 different types of personal health information. So it picks something out. It says, okay, this is a name. And then it actually replaces it. And the replacement is really important because what that means is if a malicious actor comes in and tries to look at the data, there will still be names there. It won't just be like redacted. If it was just redacted like Dr. XXXX, then if you do see a name, that's a real name, right? But now because it's masked, you actually can't tell if it's a real name or a fake name when you go in to try to go through. And so that actually adds an extra layer of protection. It also, within a document, is able to preserve date relationships. So like if it shifts the dates from September 24th to October 9th, it'll shift all the dates in a document by the same amount of time, preserving temporal relationships. But what's really interesting in work to come in the future, it doesn't do that so well across documents. And so like imagine you have multiple, you'd ideally like to preserve that across an entire hospital encounter, right? So this is an interesting challenge that we're kind of trying to work on. So when we first started this work with Gemini and started doing this research, there were a lot of skeptical people, I think rightfully so, about the idea that we could extract reliable information from hospital electronic health records. And they really pushed us on data quality. So we said, okay, fine, we've heard your concerns. And so what we did was we did a study, which we published in GEMINI in 2021, where we sent we send people now to review all of the review a sample of the records. In this case, we didn't know how many to do, so we kind of just brute forced it. We said, like, why don't you go review like roughly 1,000 records at 7 hospitals? Because we started with 7 hospitals. So we sent people to go review like way too many records, and what they found was that our data, actually, we found a bunch of problems. We fixed those problems. Once we fixed those problems, we then were able to across a range of different data tables say, okay, what we have extracted matches what you would see in the electronic health record 98 to 100% of the time. We then went to update it, which is this, because we said we don't have the resources to send someone every time we receive data. So Gemini, I didn't say this yet, Gemini receives data every 3 months from about a third of our hospitals and every 12 months from the rest. Okay, so it's not close to real time. We'll talk more about that. But it's sort of comes in these batches. We can't be reviewing like thousands of records every year, right? So we asked ourselves, well, how much can we automate and how can we simplify manual data collection? So we have a bunch of these now semi-automated quality checks, somewhere between 8 and 13, depending on the data table. So a semi-automated quality check would look something like this. You get in, this is a lab table. You get in a lab table and we plot over time the number of records, right, in a plot. And suddenly we might see, oh, here's a big jump, right? And what we found here was we were getting a lot of duplicate data rows. And so we went back to the site. We told them there's something wrong with your extraction script, fixed the issue and moved on. So what we did was across 2 years of data collection between 2021 and 2023, roughly 460,000 patient admissions, we developed these semi-automated checks. We applied them. We found across that 79 issues requiring correction. So this is like a big effort to make sure that because things change at hospitals. One time, a hospital changed their sodium lab value to be read as Na. And so if you've ever done statistical programming and you see Na, the computer thinks that just doesn't exist. So all the sodium tests went to 0 and we had to fix that. So stuff like that. And so the automated checks, we call them, they're semi-automated because a human still needs to look at it. Like, so we have data analysts that look at these checks every time. Hopefully going to work towards a situation where we actually have AI looking at all of them and then flagging potential problems. But for now, humans look at them. And so, but having fixed these 79 tests, the question remains, how much manual validation do we still need to do, or do we need to do any at all, right? So what we found was we manually abstracted about 2,600 encounters, and we actually found four meaningful errors. So the slide says only four meaningful errors, but like those four meaningful errors were really meaningful errors. So in three sites, they meant that the transfusion data was totally unusable. Like their dates and times on transfusions were totally unreliable, right? And at one site, the physician names were totally unreliable. And so the reason that those weren't caught is the errors were not systematic. There was just scrambled data. It didn't show up in the semi-automated check. So just the times were all wrong, but they weren't systematically wrong. They weren't shifted by 12 hours or something that we could see. So this happens, and it happens sometimes. So our takeaway from that is we need to always do some manual data checking because we can't miss. Like if you did a transfusion study off of this, right, or ran a transfusion trial, heaven forbid, and now three of your sites have totally wrong data, that's just unacceptable for the level of rigor that we need for a research data set. But the question is, how many records do people need to look at? So we did a simulation study. We had our reviewers had reviewed somewhere. We were just ballparking. We were like, get them to review 100 records, get them to review 50 records. So what we did was we said, well, why don't we simulate? Like if we can resample and we can take a random one sample, a random two, a random three, random four, and you can do that bootstrapping, and you can see like how often would you detect the error, right? And so we ran that simulation experiment, and what we found was that for most of the errors, especially in the transfusion data, you capture them 95% of the time. That's what this red dotted line is, after having reviewed less than 5 records. And almost 100% of the time, like this site, there was one error. As soon as you reviewed one, you caught the problem. With the physician table, it took us 18 records before we could review. But now we have some empirical evidence to tell us like how much we can review, which is a huge benefit because we can basically tell. So the people who do the review are usually like investigators at the site. So they're often clinician researchers. A lot of our hospitals are community hospitals, so it's clinicians doing this like off the side of their desk. They're not even researchers. So now we can like say, instead of spending your whole day doing this, right? They have to carve out a day. They can now spend like an hour and review 5 samples instead of a couple hundred. So that's been a major step forward. So we spend a lot of our time doing this, which is like data quality work. And you can imagine it's reasonable to do with a large scale enterprise. No single research initiative like project should spend all its time doing this. You'd never get your research done, right? So having talked about that, let's talk about applications. So we spend a lot of our energy, and I should say we have a team of 40 people full time that do that assemble the data set, make these data available, et cetera. So it's a huge team effort. I want to just talk to you maybe through sort of 3 types of applications, one related to quality, one related to kind of clinical trials, and one related to AI. So Gemini actually started, I mentioned, in 2015 with a pretty simple question. So this is our first sort of group of investigators. We just asked a simple question. Most of us are general internists. Most of us trained together, like we were in med school together or residency together in Toronto. We ended up at different hospitals. And we just asked, like, what's the quality of care we're providing on our wards? That's kind of what started this whole journey. And we said, well, to answer that question, we need data from our hospitals. And we just asked around, do you have data? Do you have data? Do you have data? No one had data. So our mentors told us to do chart reviews. They were like, they gave us a grant. Like we had actually someone had extra money sitting around. So we got a grant. And they said, with this money, you can do 500 chart reviews. So we do 500 chart reviews, like a couple hundred at each site. And then you'll get a sense of the quality of care that's being provided. So we spent a whole summer writing down everything we wanted to chart review for general medicine patients. And it ended up being a list of like 2,000 data elements that we were going to try to collect. We're like, this is just crazy. And it was also, electronic medical records were coming, and we're like, why are we doing this manually? Why don't we just try to do it by the computer system? Our mentors told us, because they had been trying to do this for 10 years prior, getting the data out of computers is like a fool's errand. It was, people had spent millions of dollars, they'd been unsuccessful. And I think honestly, we were just kind of caught the technology at the right place at the right time. Like it was just finally getting almost good enough that we could get reasonable data out. And most hospitals at that time still didn't have a data warehouse, or they didn't have like this data analytics solution, but there were people that wanted to do it. And so we went to 7 hospitals, and we basically started with that question. And we're convince them all to give us about 200,000 patients worth of data for the same grant that we would have done 500 chart reviews for. And that was really what started this whole project. And so we were focused purely on general medicine patients. And in our sphere in Ontario, there was no systematic focus on measuring the quality of care in general medical patients. So general medical wards, if you haven't worked in that context, patients who maybe their condition doesn't fit a single subspecialty area, they end up on a general medical unit rather than a specialty unit. Historically, research and quality measurement has always focused on specific disease conditions, right? So we know a ton about what to do if you have a stroke or what to do if you have a heart attack. What we don't know is if you have a stroke and lung disease and kidney disease and you end up on a general medical unit and you're frail, like what is good quality care, right? That was, people hadn't really been thinking about that at the time. So we started with just like counting general medicine patients. And we found that there are about 40% of emergency admissions to hospital. And our government, which was very interested in what they called hallway healthcare, suddenly became very interested in general medicine because they realized that our patients, the elderly, frail, complex patients, were the ones who were kind of driving up the volumes and sitting in hospitals. And so that was kind of how we got some political buy-in to do the work. And we told them, look, no one's paying attention to the quality of care that these patients are receiving. And so this was actually maybe the first plot we ever created with GEMINI. And it looked at quality of care across these 7 initial hospitals, which we ultimately published in the BMJ Quality and Safety. So within each hospital, what you can see here, each bar represents a physician, okay? And the y-axis is the total length of stay for patients. This is over several years of data. So each physician is caring for hundreds to thousands of patients. And what you can see immediately is that there is a large variation across sites. So site E has an average hospital length of stay of 6 days. Site A has 4.9 days, etc. But obviously sites care for very different patient populations, right? What's interesting is within a hospital, you see huge spreads, right? Really wide variation. So hospital D, between the 10th and 90th percentile physician, 2.3 days on average length of stay difference. Within a hospital, physicians on general medicine don't get to pick their patients. Your patient is whoever shows up when you're on call in the hospital. So there's this sort of pseudo-random allocation of patients to physicians, which if it's true, it means if we see differences between physicians and their care teams within a hospital, those relate to care, not relate to patient characteristics that are different. Does that make sense? That effect of sort of the pseudo-randomization or quasi-randomization is actually a very useful research instrument as well, which we'll come back to. Prior to this work, physicians didn't know, like if you were this physician at the top here or this physician at the bottom, you would never have known, right? Like we didn't receive any feedback about the care we were providing. So we wanted to interrogate the question. So let's ask if that pseudo randomization really holds. So what we've done here across is we've split up the physicians, okay, into 4 quartiles based on, here we're looking at readmission rate, okay? So this is their hospital readmission rate. And so what you can see is these are the physicians with the lowest readmission rate. These are the physicians with the highest readmission rate. And there's like a, 4% absolute difference, which represents like a 40% relative difference. So this is a big effect across the quartiles. Importantly, the quartiles are determined within each hospital, okay? So we're not taking, so it's the people who have the lowest readmission rate at each hospital, they all get pooled together. So now let's look at the patient characteristics of those physicians. If pseudo-randomization holds, this should look very well balanced. This is a standardized mean difference. So by convention, a standardized difference of less than 0.1 represents good balance. It's like the opposite of a p-value in terms of like conceptual interpretation. So it's pretty striking, actually. If you look across age, gender, comorbidity scores, admitted on weekdays, weeknights, previous hospitalization percentage. LAPS is a lab-based acute physiology score that's an excellent predictor of hospital mortality risk. They're all beautifully balanced, right? So this gave us a lot of confidence that actually our effect that we're seeing here is not driven by patient differences, because actually, yeah, pseudo randomization really holds, and that's what we published. And so now when we see these physician differences, it helps us think that these are real differences between care providers because of that pseudo randomization. So we took those initial variations in care, especially at the physician level, which previously had not really been focused on. We took it to the government and we said, you really, we have an opportunity to improve care here. And so the government had an agency responsible for quality. It was called Health Quality Ontario. It's become Ontario Health. And so GEMINI started working with that agency, and the government set up a provincial quality improvement network focused on general medicine care called the General Medicine Quality Improvement Network. And then GEMINI took our data and we turned it into these practice reports. So now every year, physicians in our network, which is roughly 500 to 600 physicians across now 35 hospitals, they receive a quality report that looks like this. And it's like an interactive online portal that people can go to, and there's a bunch of different indicators, and you can kind of click through and you can see your care in comparison to your colleagues. You could break it down by diagnosis. You see how your care changes over time, and it gives us some insights into practice. So like for me, for example, I learned that I'm actually pretty good at not ordering too many tests, which is good. But I was probably too aggressive about discharging patients from hospital. Like I had very short hospital stays and I had a pretty high readmission rate. And so I actually changed the way I practice a little bit to be a little more cautious and careful around the time of discharge. And actually, I saw my numbers change over years. So it actually led to some sort of tangible personal change and reflection in my practice, which I find really helpful. Hospitals also receive a report. So we've since developed a framework for risk adjustment that incorporates a lot of the rich clinical data that we have, so that allows us to create a risk adjusted report for hospitals so they can compare their care for general medicine across the other hospitals in the network. And this is really nice because what happens is within each hospital, the care groups get together. So the physicians get together. We discuss our individual data, but that's like a little bit scary to like share your individual data with your colleagues, right? But this is really nice because it kind of galvanizes the whole group together. You can see, oh, our hospital is an outlier. Maybe we have really high length of stay, so that's something we should focus on. Or it also gives people opportunity to celebrate really good work that they're doing. So these are our hospital reports. The last thing related to quality that this platform has created is a really nice sort of feedback opportunity where clinicians and also like clinical trainees, so a lot of residents and medical students, can ask all sorts of different questions, like simple health services research questions that we can answer pretty quickly. And so, I think I've kind of lost count of the number of papers published off GEMINI, but I think it's upwards of 80 or 90. And uh, uh, they can ask questions that people are coming through, and they just ask simple clinical questions that we can pretty quickly answer. And we've been able to do a wide range of health services research using this, and it's a nice feedback loop because then we take that research, we feed it back to the quality network. The quality network thinks about what they could change or improve related to the research, and it kind of creates a bit of a nice cycle there. And I'll speak a little bit about some of these going forward. So this is actually a perfect example of that. So we're, and I think we're getting perfect. Yeah, maybe 10 more minutes and then we'll do Q&A. So I think people are aware, obviously, antibiotics are overused. We try not to overprescribe them. They can cause harmful side effects to patients and also lead to antimicrobial resistance. We did a study where we took advantage of that physician pseudo randomization to look at variations in antibiotic prescribing. So this is just 4 hospitals. On the y-axis, you see the days of therapy. That's the number of days with an antibiotic prescribed divided by 100 patient days. So, what you can see here is that there's a pretty wide spread across hospitals. So the top prescriber here prescribes antibiotics like 19 days out of 100 more than the bottom prescriber. Here it's way higher, 56.6%, etc. So we see large variations in the way we prescribe antibiotics. What is helpful now is we can then look and see because the patients are balanced in their individual patient characteristics, we can ask, does prescribing more antibiotics lead to better patient outcomes, right? And turns out it doesn't. So we looked at the association between physician antibiotic prescribing and patient outcomes. And what we find is there's essentially no improvement with more antibiotics that you prescribe. They're all the odds ratios are non-significant, and uh, suggesting that there's a real opportunity for stewardship. And so this led us to get a CIHR funded RCT where we're delivering feedback back to clinicians about the antibiotics that they are prescribing in a letter. We'll randomize physicians to receive or not receive the letter, and then we'll see what effect it has on their antibiotic prescribing. Similar studies have been done in long-term care, in primary care. It's never been done in hospital, and it's a challenging space in hospital because we actually need to be careful not to underprescribe antibiotics, right? Like there's a real risk of underprescribing. So there's a potential for safety issues here. So that's why it's like a really fruitful area to study within RCT. And so we're underway. I think our letters are going out this fall, and then we'll follow up. And the nice thing is all the data collection is totally passive through Gemini, right? So what would have been if we kind of did a budget for if we collected all the data purposefully for the study itself, it would have costed between $5 and $8 million to run a large scale study like that. Like basically, 600 physicians receiving a letter about their antibiotic prescribing, then following those patients for their outcomes. Right, that's a really expensive study to run. With Gemini, we can run it for less than $1 million, just data analysis time, basically, and data quality checking and stuff like that. So, creates a really nice opportunity for pragmatic trials. Okay, last kind of broad section. I wanted to talk a little bit about AI, in part like applying AI, but also from a research methods perspective, how we can use AI to enrich our data sets and only enable us to do more kind of observational research. I've spoken a little bit about sort of some AI technologies for data quality, but this is a little different. So delirium is a leading cause of hospital harm. It's a state of acute confusion that affects 20 to 30% of adults when they're hospitalized with a medical or surgical problem. It's a major problem. When people who develop delirium, they have much worse outcomes than people who don't have delirium. They stay in hospital on average 8 days longer. They're 2 times more likely to die, 2.5 times more likely to end up in a nursing home. And it costs like $11,000 per patient more to care for someone with delirium than without delirium. And it's also very distressing. Like it's a very emotionally distressing thing for people and their families. Delirium also has really important equity gradients. So this was a study we did off of Gemini where we looked at the relationship between people's language and the care they receive for delirium. People who don't speak English, so if you don't speak English, in our context, we don't have to think about French, but people who don't speak English, when you're confused, it's much harder to communicate. It's much harder to calm someone down, settle them down. They're 2.5 times more likely to be physically restrained to a bed, like tied down to a bed to prevent them from hitting the nurse or from falling or hurting themselves. They're 1.5 times more likely to receive an antipsychotic sedating medication. So, suggesting that there's really important problems with equity related to delirium as well. The good news about delirium, it's highly preventable. So, 14 randomized control trials have shown that if you implement a bundle of interventions that includes things like keeping people stimulated, so like keeping them focused on the date and the time and engaged, getting them up and moving out of bed, making sure people eat well, making sure people drink well, making sure they have their hearing aids and their glasses. Like if you do all of that and do it really well, you can actually prevent 40% of hospital-acquired delirium. The problem is hospitals seem to be purposefully built to do the opposite of all those things, right? Like we keep people tied to the bed. It's really hard. The food is terrible. It's bright all hours of the day. It's cold. You don't sleep, right? Like it's literally the opposite of all these things. And there are sort of two barriers. The first is that delirium is very poorly measured in routine healthcare data. So if you use administrative diagnostic codes for delirium, you identify only 25% of delirium cases, which means that when hospitals look at their routine data for quality measurement, their delirium rates are 3%, 5%, when we know it's actually 20% on the unit. And so this creates a major barrier for hospitals to make delirium a quality improvement priority because they say we can't measure it. How can we improve it? I can't put it on my corporate quality dashboard to decide if we're improving it if I can't track that measurement reliably. The second problem is that these interventions are very labor intensive. It takes a lot of nursing care or personal support worker care to implement all that. And that's the very part of our healthcare system that is the most short staffed, right? So we have some opportunities for AI. So the first is that we can use AI to use the full medical record and measure who did and did not have delirium much more reliably than the coded medical data. And the reason we can do that is delirium has kind of a pattern of care. When someone becomes delirium, they often get the same lab tests. They might get some imaging tests. They might get, they have a clinical note might say confused or some other synonym for delirium. So there's like an electronic signature of delirium that just didn't work its way into the administrative coded data. So we can use AI to maybe put all of that together and determine whether or not someone had delirium. The second thing we can do is use AI to develop a tool that predicts when someone shows up at hospital, what is their risk of developing delirium? And we could then focus our prevention efforts on the high risk patients. Because let's say we can't prevent it in everyone, we have a small amount of resource. We could at least triage it to the people that need it the most. So these are the two areas that we've been working on. So the first thing we need to do was to create a cohort to study delirium. So there is a validated method of measuring delirium that is a chart review. You send someone in and they do, it's like 30 minutes to 120 minutes, a detailed review. They have to be a trained clinical reviewer, but they can identify delirium with a high degree. It's like 80 to 90% specificity, sensitivity. And that method, it's called the Chart-Del method. We applied to about 8,000 admissions across 6 hospitals, creating one of the world's largest delirium data sets, like with reliable delirium measures. And we linked it to GEMINI. So we have all the rich electronic health records data, and then we have the delirium label. And then we use that to develop a gradient boosted tree tool. So it's a machine learned tool that can accurately estimate the delirium rate of a hospital. So this is one hospital. The bars are just like the number of charts we reviewed in each time period. And what you can see here is the orange is the true delirium rate based on the chart review. And the blue dotted line is the model's predicted delirium rate. It's not perfect, but it's pretty darn good, right? It tracks really well. So now hospitals can receive a automated dashboard just with the data that they submit to GEMINI that tells them their delirium rates on their different units in the hospital, and they can use that to measure quality. It also creates an exciting opportunity for research because now in these large observational data sets, we actually know who did and did not have delirium with a high degree of reliability. So we applied that to ask a specific question, which is how often are patients sent for brain imaging and how often does that yield a diagnosis? Because we have this sense that mostly it's not useful. And so we applied this tool to every general medicine admission at 13 hospitals in our data set, represented about 30,000 hospital visits. The ML tool, like there's no way we could do 30,000 chart reviews. The ML tool found that 17% had delirium. And then we found of those, half received a CT scan or brain image. So we order brain imaging very commonly in people with delirium. Well, how often does it actually reveal an acute abnormality? It turns out 92% of scans do not reveal anything abnormal. About 8% have some kind of acute abnormality. So this suggests there's a really important opportunity here to identify which patients should and should not have scans and probably be more stewardly in who we order these scans. So that's the observational retrospective part. Moving to point of care, we've developed a point of care prediction tool now, and we're actually focusing on keeping it very simple. So on this study, we looked at just 15 simple predictors, again, using machine learning to identify the predictors. And we created a tool that works pretty well, has an area under the curve of about 78%, 0.78, at predicting who's going to develop delirium in hospital at the time they show up at the door of admission. So that now we can say, okay, if I only have enough nurses to get so many people up out of bed and fed and focus on them, we can focus on the highest risk patients. And so this work has led to a Government of Ontario funded project where we're using our point of care tools and our delirium quality measurement tool bundled together with a QI intervention to try to prevent delirium better at 13 hospitals in Ontario. So it's a start, but I think we really need to do this work at much larger scale. There are two big problems with AI. This is my last set of slides. Will be done in maybe 2 minutes. So there was recently a systematic review published of every large language model study published between 2022 and 2024. Out of 519 studies of like ChatGPT and all of these other models, only 5% used real clinical data. Most of those studies were focused on synthetic data. So AI will not be reliable for us to use in a real clinical setting if we continue to have this ratio of research happening in fake data, like research data sets that are not real world data, or versus real patient data. The second thing is we basically do no randomized trials of AI. So this is a scoping review that looked at every randomized control trial published about AI. During this time period, so we do about 20,000 drug trials in the world every year. So during that time period, there were 100,000 RCTs of medications. So I'm going to pause and ask you to guess how many AI randomized trials happened in that 5-year period in comparison to drug trials, like of clinical AI solutions. What do you think? 2, better, more than 2. You're a real pessimist. You said 100. Yeah, you're pretty close. So only 86. Okay, there's only 80. That's like a fraction of a percent, right? And only one in Canada. This we are not gonna like people talking about like, oh, AI is gonna transform medicine. It's not gonna transform medicine if we allow this state of affairs to continue. But we need infrastructure to do it, and so that's the this is the closing thing. That's what we're working to build, and that's what I'm collaborating with people here, David Buckridge and others at McGill, also at CHUM and Laval and others in Quebec. The vision is to connect hospital data from Quebec, from Ontario, from Alberta, essentially hospitals serving 20 million Canadians, receive that data not 3 months after the fact, not 12 months after the fact, near real time, like every 24-hour updates for 20 million people, and make that available with that same kind of governance structure around it for research and innovation. If we really want to allow data to improve care, to drive our research, and take advantage of all this rich clinical data, we have to start doing this at scale, and we have to dream big. And so, thankfully, the federal government gave us a $30 million launch investment to start building this platform. And so that's what we were starting to do. So literally, the funding came through a month ago. And so it's going to be pulling together clinical data, bringing it together with kind of I talked about some of the data pipeline work that we're doing. Like we're building off of an established foundation, like a decade of work putting this together, but now we really need to accelerate it to the next level. And really excited. We're calling it the Vital platform, or Vital, and really keen to move that ahead. And I'm hoping it'll create lots of opportunities for our group to work more closely with your community. So I'll end there, and thank you so much for having me.
Thank you very much. This was an outstanding presentation. So I don't know, do you usually take the questions on a line first or in the room first? Okay. The room first or? Okay, there you go.
One of them has been there for a little while. So Dr. Bernatsky asks,
Hi, Sasha.
the grants put money back in for your cost recovery?
Yes. So we have to cost recover from investigators to support all the data quality work and stuff. Yes.
How much? How much money?
Good question. There's a so depends a little bit. There are two mechanisms. First of all, the data are accessible. Please come use it. Go on our website, geminimedicine.ca. It tells you how to access the data. We would love to collaborate with you. Send me an email, like, would be great. Sasha, it depends a little bit on whether your analyst is going to do the work yourself. And things have evolved from when we did a collaboration with Sasha. Things have evolved since then. If the research team's own analyst is going to do the analysis in our computing environment, the costs are pretty low. We try to keep it to like $3,000 to $5,000 of just data access in terms of that's like REB, getting your data set cut, software licensing. And then other than that, you just kind of do it all yourself. If we need to do the analysis for you, then we bill out based on an hourly rate.
Sasha confirms that they've collaborated with Gemini and it was a great experience.
It was a great experience for us.
The other question is from Nandini Dendukuri. one of our biostatisticians. A very impressive body of work. Have you published your work on data quality evaluation? You had mentioned using a bootstrap style approach. If yes, where?
Yes, it's all in that JAMIA 2025 paper. I'll share my slides, and I kind of screenshotted the header of it. So the bootstrap evaluation for data quality checking was in that paper. Absolutely.
And then one last question from Dr. Robert Platt. Is there potential to link the Gemini Vital data to claims outpatient data?
Yeah, we've been doing it in Ontario. So we link Gemini data to ICES, outpatient data in Ontario, and we're doing a bunch of longitudinal studies with that. Would have to explore what exactly that would look like here in Quebec, but I think that would be the goal for sure.
Thank you. There.
Really great talk, really inspiring. So two easy questions. The first is to really make Gemini happen in Ontario, did it all have to be framed around quality improvement, or was there some high level acceptance that this data, like patient data, can be, used for research by external investigators without consent? First question. Second question is, so the people at these community hospitals who are pushing the data, then doing some QA, you're paying them through cost recovery, or it's the government is helping with this overall issue?
Great questions. Okay, so on the first one, yeah, to make this work, it all had to be oriented around the work, the analysis that's happening supports quality improvement at hospitals. Now, from a legal perspective, it's still all research. Like even our quality reports that we deliver back, we do under the research ethics framework. But to get buy-in from hospitals, especially community hospitals, why would they invest the energy, right, to very scarce resources to support an initiative like this if the whole outcome is just harness our data, use it for your research, right? It's not like that. It had to start with essentially, and the way this has worked is a clinician at each site goes through their clinical lead and says, we want this. We want these quality reports. We want to be part of this quality network that we participate in campaigns. So we're currently doing a campaign to reduce sedative hypnotic prescribing in hospitals. So people want to be part of that quality network. That's the motivation for 70% of the participating hospitals. The 30% is the researchers that also have the net benefit. And I think there's a very nice marriage there. But it does have to be kind of quality first. The second question in terms of how we pay. So we get research grants. Most of Gemini. So when Gemini started with 7 hospitals, we went to 30 hospitals because we got a CIHR grant to study COVID. And actually, all the hospitals were interested in sharing data in the pandemic to learn about each other's COVID experiences. That was actually the big accelerator to go from 7 to 30 hospitals. And in that grant, we had some one-time funding to give some tens of thousands of dollars to each hospital to do the initial data extraction. Thereafter, we actually don't pay anyone anything to do it, and hospitals do it because they get their value back and we don't charge them for their quality report. So there is an analogy, in the US, there's this, and I don't know if any Quebec hospitals have the National Surgical Quality Improvement Program, but essentially hospitals pay $30,000 to $50,000 a year subscription to be part of this benchmarking network, share their data, and get. So it's kind of like a quid pro quo.
Thank you. So I see Dr. Dasgupta has a comment and a question, so we'll go with her.
Hi, Suzanne. Hi, Amol. So sorry I can't be there. I'm
Sorry to miss you too.
Yeah, it's really brilliant what you've presented. So when when I was in Ben's position as core director, we tried, to work with David, and we got data analysts in and try to really revamp the warehouse. But what you've presented is so far ahead of that. One of the challenges we've faced are Quebec laws and jurisdictional issues and data sharing issues. And I'm really hoping, since I'm, seeing Ontario, Alberta, Quebec mentioned here, that your example can accelerate what's happening here. Because the challenge is often that, we'll get a grant from the Quebec, CIHR, but then the actual operations happen under the health jurisdiction within the provinces. So do you have any sort of notions of how open? I'm asking you about us, but how our governments are, our government is allowing us to participate in this, because frankly, from what I see, I would say we will sign up at the MUHC and send you our data. Please, take us on, and we would be happy in GIM to send you our fellows so that, we can have people that can have a good bird's eye view of how the whole operations has worked. And frankly, I mean, you say you sort of finished in 2016, if I understand. You guys are brilliant that you brought this to fruition in this period of time. Anyway, go ahead and comment.
Thanks. Extraordinarily generous. That thing that you just said, like we will participate. That's how we built Gemini, like one hospital at a time. So I will start with like a huge amount of like humility about the Quebec context. I don't know much about the Quebec legal framework at all, or the specific barriers. And I don't think that our progress in one province is necessarily translatable through the same approach in another province. We will figure it out. But I do think that, so in Ontario, we also have actually a provincial government repository that hosts actually a lot of electronic health records data that since we started, people have been saying, why are you building your thing? Like, just use that thing when the government lets you use it. The problem is for 10 years, they haven't created a pathway to let people use it. There hasn't been the legislation. And so we have had to build it kind of one institution at a time. And I kind of think we might take a similar approach. Like, what, Kabir, what you just said about like McGill could be a part of it. We'd love to form that. Again, that clinical tie is so valuable, right? Like bring trainees in. A lot of the research projects we mentioned, it's all resident research projects, right? So that's how I hope we will build it here while we in parallel work with the government. Whatever happens with Santé Québec, what Epic, who knows, right? But we would like to be the first initiative or at the front of the line when the government decides they're ready to do something. That's kind of what's happened in Ontario. They're really, the provincial government is a major funder of Gemini now, even though 10 years ago people were like, don't bother doing this. And it's because they see the value that we've built something outside that they haven't yet had the ability, like from all the constraints that government has, right? Their legal and regulatory constraints. So maybe it'll be a similar track where we kind of work in parallel. We engage government, maybe take advantage. I understand there's some new privacy laws that might help here. So engage and work with government, but simultaneously, let's just work with the institutions that want to start working and can do this, and then, grow organically.
Thank you.
Yep.
So I'm going to take one more question here in the room if there is. If not, there's a question here I think that would be interesting. So it's from Dr. Majnemer. Fantastic work. I hope policymakers are using this information to inform decisions. Do you capture pediatric hospitals, rehabilitation centers? She said she doesn't see the hospitals listed on the Gemini website.
Thank you. So I think the hospital, it's been a little while since I've looked at this part of the Gemini website, but I think there's a website section that says partners, and then I think there's a tab for hospitals. So we received a grant from the Ministry of Health in Ontario actually to build this platform for pediatrics about 18 months ago. And so we are building it out for peds right now. With the leadership of pediatric colleagues, it's always led by that group. So that is happening right now. I'm not even sure if the peds hospitals would be reflected on our list on the website yet, but the peds collection is happening right now. Rehab hospitals, we're at an earlier stage. We're having some conversations with a few of them, but we haven't started collecting data from rehab hospitals yet.
One last question, because it's pretty much a yes or no question. DID is quite interesting. Curious if you're allowed to make these DID notes available to researchers.
Not at all a yes or no question. We're working on it. We weren't although we published and we were happy with initial results, we've been a little cautious about extrapolating those results. And so we're actually reevaluating it all in a larger body of work right now. And starting to use those clinical notes for research. So soon we hope to be able to make them available for researchers in our sort of secure environment. So it's kind of yes, soon.
All right, so we're going to stop here. So thank you so much. This has been really a very interesting and actually stimulating presentation. And thank you for all of those who were online for your participation. And thank you. And I'm sure you could stay around a little bit if people have other questions.
Thanks so much for having me.